If you're considering hormone therapy or HRT for menopause or perimenopause and wondering if it will help with weight gain, mood swings, or brain fog, this is the breakdown you need before starting. Here's what we'll cover in this video: how HRT actually works, not just the estrogen part, what to expect when starting it, why progestogens matter for safety and what the risks are, how long it takes to work, who benefits, and what delivery methods are best. So, HRT means hormone replacement therapy and often includes estrogen and progesterone or a progestogen, which is synthetic progesterone. Estrogen helps relieve hot flashes, improves sleep, reduces brain fog, helps support vaginal health, and can potentially aid metabolism. Progestogen or progesterone is added for women with a uterus to protect the endometrial lining from estrogen's proliferative effects, meaning estrogen causes growth of the uterine lining. And so we need a progesterone to avoid the effects of unopposed estrogen, which can increase the risk of things like endometrial cancer. Common delivery methods of hormone replacement therapy include the patch, orally, gel, the IUD, or the vaginal ring. So, the first thing, let's get out of the way, is hormone replacement therapy and weight loss. Will it actually help? Hormone replacement therapy is not a weight loss drug. And interestingly enough, when you go into perimenopause and menopause, one of the things that happens due to a reduction in estrogen is actually a distribution or a redistribution of your weight. Meaning, a lot of the women I work with are going to find that they have this change in where they hold weight. They typically report having a spare tire or this belly fat that increases. And that is an actual real phenomenon that happens with perimenopause and menopause. We see this directly as an impact of the hormones. However, when we add the hormones back in the form of hormone replacement therapy, unfortunately, we do not see that same effect to where the weight that was gained comes off. But we do know that there's a multifactorial reason why women in this age range gain weight. And some of that can be poor sleep, dysregulated nervous system or increased cortisol, and blood sugar dysregulation. So we do know that HRT can reduce symptoms that lead to weight gain. Again, improving sleep, managing that nervous system, and regulating blood sugar. We know research says that women who sleep better and regulate their cortisol tend to have an easier weight management time. So, you still have to address insulin resistance, nutrition, and muscle mass. HRT supports that terrain. It doesn't get you that direct outcome. Next, what to expect when starting HRT. So, some of my patients will have symptom relief as soon as 2 to 6 weeks. However, full effects on mood, cognition, and sleep can take up to 3 months. So, normally I'm telling patients when we start hormone replacement therapy, I want to give it a solid 12 weeks. And sometimes that can be frustrating when you're dealing with sleep issues and night sweats and that sort of thing. But we need to give it 12 weeks to see the full peak effect, at which point we can determine, based on objective measures and symptom scales, such as the menopause rating scale, what our next move is. Now, hormone replacement therapy has been shown to improve hot flashes, night sweats, mood swings, brain fog, vaginal dryness. What does not happen immediately? Fat loss and instant mood stabilization. So, tracking your progress and having those regular follow ups with your practitioner in order to see if the dose is right or needs to be adjusted is actually really important. Now, let's talk about the double edged sword, understanding progestogens. So, progestogens or synthetic progesterones are necessary for endometrial protection, but come with trade offs. Some types are actually linked to increased breast cancer and clotting risk. Others, like micronized progesterone, which is the bioidentical progesterone, dihydrogesterone, and the IUD are actually seen as safer alternatives when we look at the research. Now, again, progesterone or progestogens are there for a reason, to blunt the effect of excess estrogen. But a personalized approach is always important. If one type of progesterone, whether it's bioidentical or synthetic, doesn't fit well with you, work with your practitioner, because there are a ton of options we can use when it comes to managing side effects and managing risk so that it makes sense for you. Now, how to use the HRT patch and other delivery options. So, for the patch, this is a question I get all the time. You want to apply to dry, clean skin on the lower abdomen or the buttocks, and you want to change it depending on your prescription 1 to 2 times a week. So with Estradot, the prescription is usually twice a week. With something like Climera or another type of patch, it might just be once a week. The gel you want to rub on your arms and legs. The way that I recommend to my patients, if they have a gel or a cream, one thing we want to be mindful of is when we put it on our hands, that is going to be washed off. And so we're wasting some of that dose. So some of the recommendations that I give to my patients are to apply the gel directly to the forearm and then rub to the inner thigh. That way we're not wasting a dose by having to wash our hands afterwards. Okay. Oral, if you have a prescription that's oral, again, with progesterone or estrogen, that prescription may vary, but it's taken by mouth. And the IUD is something that is in place for 5 to 8 years at this point with the Mirena. And it basically delivers progestogen directly to the uterus with minimal systemic absorption. So some people who cannot tolerate, for example, the oral progesterone bioidentical will often opt for something like the IUD. Again, it's really important to discuss the pros and cons of each option with your provider, especially if you have migraines, a history of clotting, or a family history or personal history of breast cancer. And so, is HRT right for you? Here are the questions you want to ask before starting. You want to ask about your breast cancer risk. With my patients, I run them through a breast cancer risk calculator based on their history and their family direct first degree relatives history, cardiovascular history, and we always get an updated baseline of their cholesterol or a lipid panel, as well as a family and personal history of clots and stroke. You want to understand if you're a candidate for transdermal estrogen and bioidentical progesterone, and you want to make sure that you're monitored regularly. Hormone replacement therapy is not a one size fits all plan. And it is not a set it and forget it. This is why I make sure that I'm routinely following up with my patients at 3-month intervals until we're at a really good spot in terms of getting you to your long-term dose. The last question I get is, how long do I have to be on hormone replacement therapy? Normally, I set the bar at let's reassess around we're going to be reassessing the whole time, but we want to really assess for the final time around the 5-year mark. And at that point, we might decide whether or not to come off of it completely. And so HRT can actually change the quality of your life, but the type of hormone, the dose, and delivery do really matter. So when you're looking at your options, make sure to ask the right questions, get the right labs, and understand your risks. Leave a comment with your experience or questions, and subscribe for more evidence-based hormone breakdowns.